welcome everyone tonight. It's lovely to see everyone here and a large group of people interested in working with families. And it's also my honour and pleasure to introduce Paul McNeela, who has got mental health nursing background. And Paul also wears lots of hats. He's part of the FWA committee here, and he's been the one who's doing very good marketing and getting lots of people here, so he's been wonderful to have on board. He's also had experience in working in acute response teams and in community emergency response teams, and it's a result of that experience that he has that he's doing this presentation today.
Yeah, I started working as a mental health nurse I qualified in 1996 in Scotland. I did my training in my hometown, a little town in Scotland called Perth, you may know. After I did my training there, I did about 10 years working in London in the southeast of England. And then I had about 10 years, well, I've been in WA now for 10 years. When I first came to WA in 2016, I worked in Greylands Hospital. And they managed to keep me there for about 10 months. I then worked in Morley Adult Mental Health Clinic for about 3 years, case managing 25 to 30 patients in the community with mental illness. I worked there until they closed that clinic down. I then got a job working with the community emergency response team, where I developed a lot of experience working with suicidal individuals practically on a daily basis. And I did that job until 2012 when they closed the service down. Since 2012 I've migrated from adult mental health over to CAMHS, and since 2012 I've been working in the acute response team in Princess Margaret Hospital, which is going to be basically disbanded in October. So I'll be looking for a new job soon. So if you see a CV popping in your inbox and you need to close your service down, I'm the man. I thought I would start just by throwing a few facts and figures around. And I've got some figures here from the ABS website. The latest figures came out on the 8th of March this year, and the total deaths in Australia in 2014, sorry if I'm standing in the way here, were 153,000. The leading causes of death, may come as no surprise, was heart disease, dementia, stroke, with suicides a little bit further back as the 13th leading cause of death, with 2,861 deaths by suicide in Australia. It is, however, the leading cause of death for 15 to 44 age group, both male and female. The leading cause of death is suicide. Next leading cause of death is accidental poisoning. And the next leading cause of death is land transport accidents. So I think fair to say there's a lot of suicides in that age group. I think that shows some degree of the extent of the problem of suicide, but I would imagine that a lot of government policymakers kind of look at those figures and think, okay, suicide is quite a big problem, but it's the 13th leading cause of death, maybe we need to look at these other ones. However, if you have a look at another measure of leading causes of death, years of potential life lost, these figures again are from the ABS website. And what years of potential life lost measures is premature death before the age of 78. And as the median death for suicide is 44.2 as opposed to 81.8 for all deaths, you can see why suicide is the leading cause of death with years of potential life lost, with a whopping 97,066 years of potential life lost just in 2014. And this is equivalent to all these other conditions here. And obviously child and adolescent suicides are the biggest contributor to that figure. This graph just shows a record of suicide rates in 2014, female along the bottom, male on top here, split into 5-year age groups, and as you can see, probably won't come as much as a surprise to a lot of you, who have looked into suicide. Female deaths by suicide fairly constant over the lifespan. Male deaths by suicide much more in terms of actual deaths as opposed to attempts, and a bit of a spike up to middle age, tails off a little bit before spiking up again towards the end of life. What happens in Western Australia? The West Australian Government produced a paper called Suicide Prevention 2020. They produced that paper in 2012 and with the stated intention of reducing suicide in Western Australia by 50% in 10 years. How does WA compare with the rest of Australia? Suicide, like a lot of conditions, is measured in terms of deaths per 100,000 per annum. WA has in 2014 13.5 compared to the Australian average of 10.8 and the world average of 11.4. Another really depressing statistic about WA, West Australians from an Aboriginal and Torres Strait Island background, their rate is almost triple, 39.1 per 100,000 per annum, and the youth suicides are even worse. How does society deal with this information about suicide? According to Andrew Reeves, who has written an excellent book about counselling suicidal clients, I'm happy people want to pass it around while I'm talking. Thanks. Societal discomfort with suicide, because basically suicide is an expression of distress and hopelessness that society can't tolerate. So the voters, the readers of newspapers, the readers of the TV news say to the elected representatives, what are you going to do about suicide? They then speak to the heads of health departments, the heads of NGOs like Beyond Blue and Youth Focus and Headspace, what are you going to do about suicide? And it gets passed down the line until the responsibility of it rests often with the individual clinician. Now, Reeves goes on to argue that what Western societies then do with suicide, is we build this sort of scaffolding that he calls a prediction prevention culture, and what that consists of is hospitalisation, medication, looking at risk factors. Suicide risk factors drive the search for knowledge with suicidality. So what we're doing is we're looking at the whole population, and these depressing statistics are making us think of what can we do with this population of suicidal people, which results in the culture implying that we now know enough about suicide risk factors to predict suicide in a given population and even in a given individual at times. And suicide prevention is therefore conceived to be able to generate suicide reduction targets. Reeves argues that this prediction prevention culture has got a very exaggerated faith in these methods. So each suicide in this culture can be viewed as a failure of the mental health professional to utilise the available knowledge effectively. And the prediction prevention model dominates all suicide research and all suicide literature, and basically all funding. All of the dollars on suicide basically get dominated within this prediction prevention model. And the quest is looking for the phrenology bump on the head that will actually be a sign that you can identify someone who's suicidal with a particular risk factor. And what Reeves argues is that in this culture, I use counsellors, therapists, mental health clinicians, and I'm sure we can just use all those terms interchangeably. Counsellors and therapists fear litigation and blame, and what they do is they refer their clients on sooner than they need to, and they break confidentiality unnecessarily at times as soon as suicide is talked about. That acronym stands for Quantitative Suicide Risk Assessments, that saved a few slides. So we've got the quantitative suicide risk assessments, and I actually brought one with me. So what are some of these suicide risk factors that the prediction prevention model bases its research and studies on? There are actually over 100 suicide risk factors implicated in the literature. And I just took these 10 out as 10 of the most commonly cited in the literature. Out of that 10, according to the document Risk Assessment in CAMS, there is actually a big 3 within the world of suicide risk factors. There are three risk factors. Yeah, if you're the same generation as me, you probably did the same history lessons at school. There's a big 3 of suicide risk factors that are seen as the most reliable to predict suicides. Any ideas what they might be? If suicide risk factors was an Olympic sport, the bronze medal would go to drug and alcohol abuse. That is the third most reliable, the third most empirically based risk factor in the suicide research. 28 to 54% of attempted and completed suicides involve abuse of drugs or alcohol. But when you think about it, if you just do the reverse of those figures, this means that 46 to 72% of them don't involve the use of drugs or alcohol. So this is the third best suicide risk factor we've got to help predict who's going to commit suicide, but it barely tells us about half of them. And also another complicating factor with this risk factor is that 35% of 14 to 19-year-olds in Australia use alcohol to risky levels, and 17% of them use illicit drugs, have used illicit drugs in the last year. So just knowing that they use drugs or alcohol doesn't get us any closer to finding out who is suicidal, where the suicidal people are. The one with the second best evidence base is mental disorder. And 90% of completed adolescent suicides had a mental disorder at the time of suicide. Again, however, that helps us some of the way, but when you consider that 10% of Australians aged 15 to 19 have actually got a mental disorder diagnosis, that translates to 180,000 people in Australia and probably about 18,000 people in WA who are between the age of 15 to 19 and have a diagnosed mental disorder. So yeah, just because 90% of suicides do have a diagnosed mental disorder in this age group, doesn't really help us an awful lot. So the leading gold standard of suicide risk factors, anybody want to have a guess? Did someone say previous? Yep, correct. The gold medal would go to previous suicide attempts. If someone has made a previous suicide attempt, they are 38.4 times more likely to end their life by suicide than the general population. So that's pretty powerful, isn't it? However, again, it's only of limited help, this gold medalist suicide risk factor, because there's only actually 10 to 40% of suicides where there was a previous suicide attempt. I promise that's most of the figures out of the way. So, some of these eminent suicidologists in the field have looked at these figures and also questioned the value and the validity of risk assessment tools based on these suicide risk factors. As Schneidman says, most people who commit suicide talk about it, but most people who talk about suicide do not commit it. Which to believe? As Joyner says, most individuals will display the documented risk factors, but they will not attempt suicide, and fewer still will die by suicide. And while quantitative assessments can tell you about suicide rates of the statistical groups that the individual belongs to, but it can't actually tell you if that person's going to kill themselves or not. So, what's all that mean? What can we do about it? We don't have any of these things at our disposal. Although if I was in a desperate place, I would probably give the guy with the crystal ball a try. He looks like he could do a thing or two. We talk to them. For all the research and inquiry, there's only one way of truly understanding if someone is suicidal, and that is during a therapeutic conversation. One man who understood this is Sergeant Kevin Briggs, the guardian of the Golden Gate Bridge. Sergeant Briggs is a sergeant in the California Highway Patrol, if any of you are old enough to remember the program CHIPS. He's one of them. And his job is basically to patrol the Golden Gate Bridge and talk down suicide attempters. If there's anyone here from Youth Focus, I'd just like to say thanks very much for getting Sergeant Briggs over to Perth a couple of years ago. He did a really interesting talk, which I went along to. Very rewarding. So Sergeant Briggs has talked down 200 people between 1994 and his retirement in 2013 from the Golden Gate Bridge, which is the second most used suicide site in the world, behind a bridge in China. And 5% of jumpers survived the 75-metre fall, but most of them perished due to drowning or hypothermia. And here's Sergeant Briggs here, having a chat with this unfortunate young man who's contemplating ending his life. And here they are a few years later, having a bit of a laugh and a joke about something. This young man who he managed to talk down is also now a prominent suicide and mental health advocate in the USA. There's a study being done on the survivors of the Golden Gate suicide jump, and this quote, I'm not sure of the accuracy of it. I don't think they managed to find all 26 survivors, and I read somewhere else there was actually 40 survivors. But anyway, this study, they managed to interview 26 survivors out of 3,000 deaths, and without fail, each one of them stated that the moment they jumped off that bridge, they wanted to change their minds and they wanted to live. A bit closer to home, the Gap in Sydney is a cliff which is the most used suicide site in Oceania, with 50 suicides per year. And some of you may remember this chap, Don Ritchie. He lived opposite the Gap in Sydney, and he's a retired life assurance salesman. I sold him life, he said. He saved more than 150 people from this suicide spot until he died aged 85 in 2012. Former life assurance salesman, he said in the early years he physically restrained people from jumping while his wife called the police. In his later years he tried a more simple approach. I would say, what are you doing there? Why don't you come to our place across the road and have a cup of tea? You've got to do something, and it gives them a chance of changing their lives. So I would say, if these lay people, Sergeant Briggs and Don Ritchie, got it, why don't we? I would say part of the reason is this. When I started doing some research for this presentation, I had a look at my book collection and looked in the index for mentions of suicide or risk, and my book collection is pretty much full of mental health, psychotherapy and suicide books. It's a laugh a minute in our house. But yeah, I was really surprised that there was absolutely no mention of suicide in the index of any of these books. A lot of these family therapy texts, and a lot of these texts by real giants of individual psychotherapy like Rogers, Jung, Yalom, May, Byrne, Dr. Harris, not a single mention of suicide. Whole books about their therapeutic techniques without a single mention of suicide. And then when I did some further research and saw that suicide does get a mention, it's all about referring away. When children or teens experience suicidal thoughts, consider hospitalisation before implementing other interventions. Counsellors working with suicidal clients need to refer to other specialist helpers. part of my role in the acute response team, and some of my colleagues are here, is to be that specialist helper in the emergency department. And when they're referred to us, we talk to them and try to prevent them going into hospital. And meanwhile, the suicidal client is suffering as they're being excluded from therapy, referred away. They're seeking a chance to escape from their psychological pain. They've got a concrete, rigid belief system that there's no other alternative to managing their problems. They're ambivalent about living and dying. They've got a diminished capacity to cope with their difficulties. They've got attachment problems, relationship problems, feelings of loss, rejection and abandonment. Now I would propose to you that all these things are meat and drink to therapists, and this is the kind of stuff that therapists should be dealing with rather than referring away. I almost took this slide out because it's a bit blurry, but since I considered using this slide, I've been humming the tune all weekend, so I thought I would inflict the same on you guys. You'll see. But the good news is that the times are a-changing. I think I mentioned on my flyer that I've been co-opted onto the policy development group looking at the new policy and suicide risk assessment for the WA Health Department. And the way it's shaping up, it's looking like there's going to be a philosophical shift away from risk rating factors, from the prediction prevention model style, and it's going to be more of a person-centred approach to personal safety rather than risk avoidance. An appreciation that factor-based assessment tools are not reliable predictors of rare events like suicide. So it's going to be based on the principles of being person-centred, safety, and partnership with consumer, carer and family. Other reasons for optimism. There are a lot of therapists now who are actually writing about their experiences working with suicidal clients. The evidence base is growing. I think everyone's probably heard of Marsha Linehan's dialectical behaviour therapy for suicidal clients with borderline personality disorder. But there are other therapists who are joining in with the suicide literature and demonstrating how therapists can actually intervene with high-risk clients. Quite happy if you want to pass these books around as well. These 3 books I've brought in, I would recommend them to anyone if you want to know more about doing therapy with suicidal clients. Very helpful. If you're anything like me, you end up buying a lot of books online and you get a lot of rubbish through the post. I've got the rubbish at home. These are the good ones. Joiner's theory of suicide, this model here, I'm sure is familiar to a lot of you. I find it a particularly good way of working with families who have got a suicidal adolescent in the family. It's a really good psychoeducation tool, I find, this model. For those of you who are not familiar with it, Joyner asked the question, why do people kill themselves? And he actually said in his book, you can sum up my theory in 10 words, because they want to and because they can. So the desire, according to Joyner, is made up of these 2 elements. I don't know how well you can see it at the back there. Perceived burdensomeness and thwarted belongingness. The terminology is quite burdensome in itself, actually. But perceived burdensomeness can basically be summed up by an individual thinking, my death will be worth more than my life to my family, my friends and society. And the thwarted belongingness is about loneliness, social isolation, feeling alienated from your family, your social circle, or some other valued group. So that's the desire, but the critical part of Joyner's theory is that as well as having the desire to suicide, people will not actually go through with suicide unless they have an acquired capability to do so. And what he says is a self-preservation instinct is the strongest instinct that humans and indeed any species have got. But there are a select few who can stare down that instinct and through habituation to painful experiences, they almost sort of desensitise themselves to pain and suffering. And they can do that through repeated suicide attempts, self-harm behaviour, exposure to violence, military combat, people in the sex industry, other professions who are exposed to a lot of death and dying, pain and suffering. Doctors, dentists, vets, nurses, paramedics all have higher rates of suicide in the general population. And I probably should have asked for informed consent about this, but probably also individuals who attend suicide presentations. It's actually in one small way actually acquiring slightly a capability to suicide. But the good news is that capability is only related to suicide when it's combined with the strong desire of the perceived burdensomeness and thwarted belongingness.
What about the sort of prolonged stress from domestic violence?
Yeah.
Such as like Rosie Batty type people that doesn't seem to come out, that's part of that.
Yes, Robin, that would fit perfectly into Joiner's theory. Yeah, a victim of domestic violence is habituating to being the recipient of that violence for so long that actually, if they develop the desire for suicide, they will actually have an increased capacity to act on that desire because they've habituated to that abuse. Other models of therapy for suicidal clients, like we said, most people are probably familiar with DBT, Marshall Linehan, which combines dialectical theory, CBT and Zen Buddhist theory to assess and treat suicidal individuals. People may not be so familiar with Tony White, who's actually a psychologist in Perth, who's got, some people know Tony, who's got massive experience working with suicidal people, and his book's doing the rounds there. And he works from a transactional analysis perspective, and he's formed a theory that with all the suicidal individuals that he has interviewed, he believes that you can use the parent, adult, child ego states in transactional analysis to try and understand the suicidal decisions made in childhood. Tony White believes there are about 6 or 7 suicidal decisions we make in childhood, and most adults who then go on to commit suicide have made a decision in childhood. DBT, the 4 modules there, and these are just won't dwell on it too long because I've got another few things to cover. But they're some of Tony White's childhood suicide decisions. If you don't change, I'll kill myself. I will get you to kill me. I will kill myself by accident. I will kill myself to hurt you. So in his therapy with adolescents and adults, he tries to find out the point at which that decision was made and which decision it was. And don't have the time to go into detail here, but depending on what the decision is, it sort of dictates the treatment that's ongoing, the psychotherapy. A lot of writers on suicide talk a lot about suicidal ambivalence. And Tony White also writes a lot about suicidal ambivalence. The feeling that at the same time as wanting to die, every suicidal person also wants to live. And he found it helpful to look at percentages of wanting to die and want to live. And some people maybe feel 70-30 one day, 50-50 another day. When I read his book a couple of years ago and I came to that page where he was talking about percentages, it was almost a eureka in the bath moment for me, because I'd actually been using these percentages in PMHED. I just developed the practice myself independently. And I find that using percentages to track suicidal ambivalence is really helpful for suicidal adolescents. And it's quite a long preamble before I go into the percentages, but it's basically, so you've took an overdose of Panadol and you're now at the emergency department. can I just ask you, when you took the Panadol, what percentage of you wanted to die and what percentage of you wanted to live? Oh, about 90% wanted to die. Okay, and apparent, I think your mum said that you had a fallout with both your parents last night before you took the overdose this morning. What were your percentages then? Oh, it was probably about 70-30. And last year when you tied the noose up in the garage that you didn't use, what were your percentages then? Oh, probably about 80-20. And what about right now? Oh, yeah, I'm probably about 40-60. Okay, so that 40% of you that wants to die, it's not too strong for you to be able to resist the urges? Yeah. So you can see how that kind of conversation identifies the intensity of the suicidal ideation and the immediacy of the risk. It shows the client that the suicidal desire can be mediated by their mood and by events and circumstances. And it also builds rapport and collaborative risk management. And I also find with families who have a suicidal adolescent that discussing suicidal ambivalence with them is a much better way of understanding their behaviour rather than cry for help, or they're doing it for secondary gain, they're being manipulative, or they're not really serious, they took 10 Panadol and then phoned for help. But it's actually that suicidal ambivalence that leads to that inconsistent behaviour in most suicides.
Sorry, can you just really elaborate on the ambivalence?
Yeah, look, a lot of dialectical behaviour therapy is based on suicidal ambivalence, and Linehan actually used dialectical theory because she became aware that conventional CBT was not working with borderline personality disorder clients who were suicidal. And illogical though it may seem to our Western way of working, a lot of these clients, it was possible for them to have opposing beliefs. I want to live, I want to die. I am happy, I am sad. I am angry, I am happy. So she worked a lot with that ambivalence, trying to find the truth in the middle. So you've got the thesis, I want to die, the antithesis, I want to live, and there's a synthesis in the middle. Sometimes I want to die and sometimes I want to live. So working with that suicidal ambivalence is try to find the truth in both extremes and also the truth in the middle. And I just find it works really well with suicidal people, and particularly with adolescents.
Is that sort of like when you're saying that, Paul, that ambivalence for the client might help them to see that creates that hope that there's a bit of them, that part of them that wants to live, and so you're actually amplifying almost that part. Well, that's what you could do. You could start amplifying some of that part
Absolutely.
of wanting them to live.
Yeah, perfect timing. Another writer on suicide I came across is Britton and his colleagues, and they've built on CBT and DBT approaches to suicidal clients, but found that there was high rates of attrition and disengagement with these modalities. So they actually developed a way of working with suicidal people called MySci, might be MISI, not sure how to pronounce it, but motivational interviewing to address suicidal ideation and exploring the reasons for living and the reasons for dying. And they developed this tool, a qualitative assessment tool, developing the importance of living the ruler. And it's exactly what you're talking about, Anne. So first of all, you step one, you ask the client on a scale of 0 to 10, how important is living to you right now? The critical part that the therapist does next is, say the client says, 3 out of 10. The therapist then says, well, why did you choose 3 and not 0? And then that gets them talking about the reasons for living. And if they actually say 0, you would say, what would have to change for you to give a higher number? So again, you're using that motivational interviewing style to get them talking about reasons for living. There are some family therapy approaches to working with suicidal clients, but not very many in the literature out there at the moment. Probably the best known one is attachment-based family therapy from Diamond and his colleagues. The only evidence-based manualised family therapy treatment for depressed adolescents and suicidal ideation. Built on 5 specific tasks. The first one's with the adolescent. I think they have a sequence. I think they do a few sessions with the parents, a few sessions with the adolescent, then they get all the family together. I think it usually takes about 16 to 20 sessions. Another model that I came across in preparing for this was the safety first model, which is, there's a couple of articles written about this in the Australia New Zealand Journal of Family Therapy. Bickerton is a consultant psychiatrist in a camp service in Sydney, and her and her multidisciplinary colleagues wrote these 2 articles describing a service that they do using family interventions in the emergency department after suicide attempts, and also then in the community to enable the risk to be managed at home. They base their model on the belief that hospitalisation of suicidal young people invites them to underfunction in taking responsibility for the behaviours of distress. Hospitalisations are lengthy, expensive and unhelpful. I came across this article by Lum and colleagues who use the...
Paul, is there any evidence that hospitalisation does decrease the rate of suicide or increase one way or the other?
I think we're always going to have hospitalisation as a method of dealing with suicidal people, and I think it's appropriate, Des, if the risk is extreme and immediate. And with adolescents, I've been involved in lots of decisions about whether to hospitalise or not. And if the risk is extreme, immediate, and there's not a containing home environment for them, I think you've got to consider hospitalisation then. In terms of it being a therapeutic process, which I think is probably what your question's more about, there's probably more doubt about that. In fact, there was an article that I was going to quote in here, but I kind of chopped it down for saving time. There's an article by a guy called Large and some other authors, and they've actually done studies into patients when they're discharged from hospital in the adult population. That 12 months post-discharge is one of the highest risk periods. They've actually got a rate of suicide about 300 or 400 times the general population, 12 months post-discharge. And he also looked into the risk assessments that were done while they were in hospital, and only 3% of the suicides were considered to be high risk. So 97% of the high risk people didn't suicide, and 60% of the suicides 12 months post-discharge were low risk. And there's actually a greater association of suicide if you're in hospital and you're assessed as high risk than there is when you're discharged. So you're actually more at risk when you're in hospital when you're high risk.
Yeah, I just want to ask, do you look at the percentage or the statistics for adolescents that actually do suicide and they don't come under mental health? So they're the kids that show no indications whatsoever, they're suicided, they might have counselling, but there was nothing that showed.
Yeah.
Do you look at those?
Yeah, look, when I mentioned about 90% of adolescents having a diagnosed mental disorder when they suicide, a lot of that is based on what are called psychological autopsies, which are psychologists doing interviews with family and friends afterwards rather than actual diagnoses when they were alive. So yeah, I completely agree with you that I think most of the suicides that happen were not reaching them.
Yeah.
And again, that is a weakness of the prediction-prevention model. We think that if we just do all these statistical analyses on what the risk factors are, we'll find these people at risk of suicide, but we're actually not finding them. Just a General slide on communication with a suicidal client. I think there are a couple of bereavement counsellors here tonight, and they'll be able to tell you that when they talk to the bereaved, they don't use euphemisms like passing on or going to sleep. They talk about death and dying, and it's the very same when you're talking with suicidal people. However, at the same time, you've got to be aware that it's difficult for a suicidal person often to disclose their suicide risk, so they are likely to use some of these euphemisms on the slide. So we've got to be aware of that. When we risk assess suicidal clients, often when we're in a therapeutic situation and a client discloses that they're feeling suicidal, the automatic thing is for us to think, oh God, what do we do now? What's the risk assessment policy say? I'd really appeal to everyone, if they're in that situation, to actually first of all think, what happens now therapeutically, not what happens next in the suicide risk assessment policy. There's loads of time to sort that out. You can find someone to make the suicidal client safe, you can have someone to sit with them, and then you can do all the bureaucratic paperwork afterwards. Your safety plan should be informed by current knowledge and research, the words and thoughts of the client, and your plan should be the most appropriate intervention for the client at that time. Reflective responses can be helpful with suicide, but suicide really must be named, and we also, as well as reflective responses, we have to do explorative responses. Now, risk assessment and therapy needn't be mechanical or bureaucratic or formulaic. In fact, I'd say if it is, it's a very poor risk assessment. We don't get much information from the suicidal person. But if you had a more explorative approach to risk assessment, you actually get more information about the risk factors. And if your agency does actually require you to tick boxes, please tick those boxes in an explorative manner. Just a little bit about the dignity of risk. That refers to positive risk-taking, giving some of the responsibility for the suicidal person's safety back to them, empowering them, showing them that they don't need to be dependent on the system to prevent their suicidality. Suicidal clients, they have to deal with the anxiety and shame when they name their suicidality, so they deserve a therapeutic response, not a procedural one. There is also a risk to therapists of suicidal clients, which I think is prescient. Therapists actually have terror of some of their clients committing suicide. I think it's no exaggeration to say. And some of the therapist responses are like vicarious trauma type responses, sleeplessness, feeling of impotence, incompetence, anxiety. And the real fear of litigation and accusation of malpractice. Again, Reeves would argue that the prediction prevention model actually encourages that culture in Western societies. What's the antidote to that? Good record keeping. I don't think we need to elaborate on that slide anymore. But, you know, the humorous phrase, cover your arse, what it's about really is accountable professional practice. As long as we can provide a clear, accountable rationale for professional decisions made regarding suicide risk, paying attention to the risk factors and the knowledge of the individual client, our practice will be safe. I don't think we could go into a coroner's court and say, oh yes, Your Honour, I just had this gut feeling and I had this counter-transference with the client and that's why I acted in that particular way. But if you can actually show a clearly thought out plan based on the knowledge of the risk factors, theories of suicide, and the words and thoughts of the individual client all went into the safety plan, you're protecting your practice. If anyone's got the Reeves book, on page 147, he actually looks at one client, one scenario where he breaks the adolescent's confidentiality, another scenario where he maintains the confidentiality and justifies both courses of action. Not to be clever, but just to show that actually both courses of action are valid. We all, of course, probably have our own personal beliefs about suicide, which is only natural. Those personal beliefs probably go on a bit of a continuum or a spectrum. One extreme of the spectrum would be those of us who view the sanctity of life as precious and suicide is wrong in all circumstances. And on the other side of the continuum, we would probably have people believing there's a human right, inalienable human right to end your life when you want to, and indeed it should be legal to get some assistance to do so. Now, our agency, our employer, or our regulatory body may have a different opinion to ours on suicide. And also, like many of our beliefs, they don't have any home in the therapeutic encounter. And really it's our job with suicidal clients to help them to explore what their beliefs are, rather than impose our beliefs on them. And I would urge you just to recall the 26 survivors of the Golden Gate Bridge. So why therapeutic interventions for suicide risk? Because suicide is extremely difficult to predict. We can't predict it by statistics alone. People who die by suicide, even if they tick all the boxes for all the risk factors, are almost impossible to identify before their death. As we're demonstrating, the rate is staying pretty constant. So as we're getting more evidence of talking therapies that work with suicidal clients, they're seen as more viable and effective in dealing with high-risk people. And I guess it's all our responsibilities to integrate research methods into our practice to demonstrate the continuing efficacy of therapy with suicidal clients. And why family therapy for suicidal adolescents? Well, family therapy actually addresses a lot of the risk factors which are family-based. Family conflict, low family cohesion, poor attachment, ineffective parenting, family mental illness, family history of suicide, violence, drug or alcohol use, neglect and abuse. Family therapy can also strengthen the protective factors in a family, the protective factors that minimise the risk of suicide, like emotional support, appropriate parenting and sibling support. And family therapy with adolescents who are suicidal, there's often a lot of shame, blame, stigmatising, scapegoating certain family members for making the young person suicidal. Family therapy can address all that unhelpful content. I would actually propose that instead of us having 10-year suicide prevention targets, we actually have a 30-year plan of family therapy and individual therapy being more available to suicidal individuals as viable alternatives, more effective alternatives in the long run to pharmacology and hospitalisation. And the reason I'm advocating it should happen for 30 years, if you can remember the graph at the beginning of the different age groups of suicide, especially males, it really does hit the peak round about middle age. If we could start working on this generation of suicidal adolescents and continue for 30 years, then you could maybe make an impact on the suicide rate. In any case, I think most of these males who commit suicide in later years, if they could be exposed to family therapy in their adolescence, we've actually got an option of making them view therapy as a viable choice in a later age group. Last but not least, if you're working with suicidal clients, very important to look after yourself. The fear of getting it wrong in litigation can lead therapists to behave in a below par standard. You should know your code of conduct, consult with your colleagues, either informally or in case reviews. Use clinical supervision so you can reflect on your work with suicidal clients in a non-blaming forum. Keep up to date with PDs like this. Thank you very much. We can have questions, comments. There's actually another couple of slides I'd be quite keen to show you if I can stretch your patience a little. because I'm aware that a lot of the statistics at the beginning are quite overwhelming. So what I did was I looked at the statistics, I need a drink of water, and tried to nut them down to how likely we are to meet suicidal adolescents in our practice. So has everyone got 5 minutes or so? We could go through that. Yeah. So first of all, I looked at the age groups, and females who are 15 to 19, 5.3 suicides per 100,000 per year. So to find out how many people in that demographic you would have to meet to encounter one suicide in a year, you divide 100,000 by 5.3, gives you 18,868 individuals. Now, I then looked at, if we were all working as practitioners and whatever kind of work we do, if we work, say you get 4 weeks off a year, you've got 48 weeks of work, and say you see the client on average of 6 sessions, so 48 divided by 6, you've got 8 discrete periods of therapy per year. So bear with me on this one. So the average caseload to expect one suicide in the general population would be that 18,000 divided by 8, 2,538. So you would actually have to see 2,500, you'd actually have to have a caseload of 2,538 females 15 to 19 in the general population to encounter one suicide.
Won't that depend on which agency you're working for, though? If you're working for certain agencies, you might pick up a high percentage of that.
They might even have you seeing 2,500 people.
That's a lot of people.
And what I did then was I looked at diagnoses of major depressive disorder, and that actually increases your relative risk of suicide by a factor of 20.4. So then if you look at your females 15 to 19, it's not just general population now, they've got a diagnosis of major depressive disorder. That brings it down to 116. So you'd need a caseload of 116. So bear with me. So these are the figures that I've used. This is from a document written in Canada based on APA guidelines. And it just looks at relative risk of suicide in these different disorders. So you can see there, prior suicide, that's the figure I used, 38.4 on the other slide. Depression, 20.4. And if you remember, the other big 3 factor was drug and alcohol abuse. I did a very crude statistical thing and added both of these figures together and divided by 2 and got 12.5. So that gave me this table here. So you can see the females 15 to 19, that's the example I just recounted to you. Females and males below the age of 14, very low rates of suicide. 0.7 per 100,000 per annum, 0.3 for males. Now I'm not suggesting that a male on his 15th birthday suddenly becomes 12 times more suicidal. But you know, this is, you've got to do the cut-off somewhere with statistics, haven't you? But yeah, in the 15 to 19 age group, 12.1 per 100,000 per annum. If you do the same calculations I've just done, it kind of becomes a little bit more meaningful. So if you had a male 15 to 19 with a previous suicide attempt, you would actually need 27 of them in your weekly caseload to expect one suicide a year. It's now probably getting a bit closer to home, isn't it? If you're like my colleague in the art team, who doesn't see patients once a week for 6 weeks, but perhaps sees several patients a day, you can see that that number would come down significantly. Sorry, I didn't do the math stuff. But one thing I thought was really significant in these figures is that if you look at a male, 0 to 14, who's had a previous attempt at suicide, you would need to have a caseload of 1,085 of them. However, male 15 to 19, general population, with none of these risk factors, pretty much the same. So I just thought the relevance of these tables really was to say, yeah, the suicide statistics are very frightening, and yeah, the counselling and therapy textbooks tell us to refer away if they're suicidal, but we've got new evidence now that says, no, we should actually talk to these suicidal people. And I actually relaxed a little bit when I saw those figures, because yes, it is a terrible scourge and it is out there, but like the lady says, second from the back there, we can't find where these suicidal people are. They're not necessarily coming to therapy. So we can do this therapy, hopefully with a bit of safety of knowledge that suicide is still a relatively rare event. We don't have to be paralysed by fear with it. Anybody else got any comments or questions? Oh.
I've got a question. Hello?
Yeah.
Yeah.
I have a question. The word transgender, I see lots of transgenders 15 to 19, maybe a bit older, all expressing suicidal ideations. What the intent is there a heightened risk? Some mentioned that.
Yeah, I think they're one of the most risky groups.
Yeah.
I don't have the stats off the top of my head, I'm sorry.
Is it a relatively new trend?
Sorry?
Is it a relatively new trend? Because I hadn't experienced it probably until 4 years ago.
I think the LGBTIQ population in general, there's always been high levels of suicide. Well, they opened a gender identity service in PMH a couple of years ago, and they had to convert it from a treatment service to an assessment service because they were so overwhelmed with referrals. So perhaps having that service there is making it easier for more people to come forward. Maybe that's what you're experiencing. Sorry, this slide's me and my mum. When I was in Scotland 2 years ago, like I said, I've worked in mental health for 20 years and I've had experience of suicidality there. And also at a personal level, my mum first attempted suicide when she was in her late 30s, following a childhood of abuse and trauma. When I was about 13, 14. She's made a further 2 attempts after that, but I'm pleased to report that she's looking forward to her 77th birthday in February and her 53rd wedding anniversary to my dad in August. So I'll be seeing her next month. But look, I just wanted to acknowledge that I think when we work with suicidal clients, sometimes we use a bit of gallows humour, and I'm aware that suicide touches a lot of people, so I just wanted you to be aware that it's touched me as well, and I hope none of my humorous slides or comments have caused any offence. But I better shut up, it's 7:10. Thank you very much for listening.